Hello, Dr. D here. This video is meant for healthcare professionals to refresh their knowledge or to assist students studying to become a healthcare professional. Antibiotics are compounds that target bacteria with intention to treat or to prevent bacterial infections. It is important to know the different antibiotics and to treat the patient appropriately, especially facing the major threat of antimicrobial resistance. This video looks at the various classes of antibiotics, their mechanisms of action, and pharmacokinetic and pharmacodynamic principles. Watch this video in conjunction with the video on antimicrobial stewardship. Antibiotics can be grouped in two main categories, bacteriostatic and bactericidal. This classification is based on antibiotics' effect on bacteria. To understand this, let me first explain minimum inhibitory concentration and minimum bactericidal concentration. The MIC is the lowest concentration of an antibiotic that inhibits bacterial growth at 24 hours. The minimum bactericidal concentration is the concentration of an antibiotic that reduces bacterial density by 1,000-fold at 24 hours. With this in mind, bacteriostatic antibiotics exert an MBC to MIC greater than 4 and inhibits bacterial growth. Bactericidal antibiotics exert an MBC to MIC less or equal to 4 and kills bacteria. Examples of bacteriostatic antibiotics include tigecycline, clindamycin, your macrolides like azithromycin and clarithromycin, linezolid, sulfamethoxazole, and tetracyclines like doxycycline and minocycline. So these antibiotics will inhibit the growth of bacteria. Antibiotics with bactericidal activity and therefore killing bacteria includes aminoglycosides, your beta-lactams. Beta-lactams include your penicillins, cephalosporins, and carbapenems. Cyclic lipopeptides like daptomycin, fluoroquinolones, for instance, ciprofloxacin, levofloxacin, and moxifloxacin, glycopeptides, which include your vancomycin and teicoplanin, nitroimidazoles like metronidazole, and polymyxins like colistin. They all exert a bactericidal effect. The effectiveness of a particular antibiotic is dependent on its pharmacokinetic and pharmacodynamic properties. Pharmacokinetic principles refers to the way the body interacts with a substance, and it includes absorption, distribution, metabolism, and excretion. Pharmacodynamic principles refers to the biochemical, physiologic, and molecular effects of the substance on the body and involves receptor binding. The effectiveness of an antibiotic also depends on the bacteria itself, the bacterial load, and the site of infection. Certain antibiotics can be either bacteriostatic or bactericidal. For instance, clindamycin, which is usually a bacteriostatic antibiotic, acts bactericidal at a higher concentration. Macrolides, also bacteriostatic, but is bactericidal against selected organisms at higher concentrations. Sulfamethoxazole, also bacteriostatic, but bactericidal in combination with trimethoprim, commonly known as cotrimoxazole. The pharmacology behind antibiotics includes destroying the bacterial cell by either preventing cell reproduction or changing a necessary cellular function or process within the bacterial cell. The different bacteria is covered in another video. The main difference between cell membrane and cell wall is that cell membrane, also called a plasma membrane, is a universal feature of all living cells, whereas cell wall is absent in animal and human cells. Let us look at the different mechanisms of action of antibiotics. Some antibiotics inhibit cell wall synthesis, while other antibiotics inhibit protein synthesis. Protein synthesis in bacteria occurs in their cytoplasm, that is the liquid that fills the inside of the cell. Because bacteria have free-floating circular DNA called a nucleoid that lacks a nucleus. The process of building proteins from amino acids during translation takes place in the ribosomes. Ribosomes is thus the site of protein synthesis in the bacterial cell. Certain antibiotics can also inhibit folate synthesis and known as antimetabolites. Nucleic acid synthesis inhibitors either inhibit RNA polymerase or DNA gyrase. Then we also get antibiotics that inhibit cell membranes. Cell wall synthesis inhibitors are bactericidal antibiotics and include beta-lactams, penicillins, cephalosporins, and carbapenems. They are all beta-lactam antibiotics. An example of a penicillin is amoxicillin. Cefazolin is an example of a cephalosporin, and meropenem is an example of a carbapenem. And they all inhibit the biosynthesis of bacterial cell walls. Glycopeptides also fall under cell wall synthesis inhibitors, and they include vancomycin and teicoplanin. They bind to bacterial cell wall, causing blockage of the glycopeptide polymerization, and secondary causes damage to the cytoplasmic membrane of the bacteria. Protein synthesis inhibitors can be either bacteriostatic or bactericidal. Glycylcyclines, like tigecycline, binds to bacterial 30S ribosome and inhibits peptide chain elongation. Lincosamides, for instance clindamycin, inhibits protein synthesis by binding to 50S ribosomal subunit and inhibits peptide bond formation. The macrolides, like azithromycin or clarithromycin, inhibits protein synthesis by binding to the 50S ribosomal subunit and also inhibits polypeptide synthesis. Linezolid prevents protein translation by binding to bacterial RNA, and your tetracyclines, doxycycline and minocycline as examples, inhibit protein synthesis by binding to the 30S ribosomal subunit. They are all bacteriostatic antibiotics. The aminoglycosides, an example thereof is your amikacin. They are bactericidal and they cause code misreading by binding the bacterial 30S ribosome. Nucleic acid synthesis inhibitors are bactericidal antibiotics and include fluoroquinolones. Examples of fluoroquinolones include ciprofloxacin, levofloxacin, and moxifloxacin, and these antibiotics inhibit enzymatic activities of DNA typoisomerase and ultimately the DNA synthesis of susceptible bacteria. Nitroimidazoles An example thereof is metronidazole. A chemical reaction appears to be responsible for its cytotoxic effect, which include disruption of DNA and inhibition of nucleic acid synthesis. Sulfamethoxazole is a sulfonamide that falls under the class of antimetabolites, and they exert a bacteriostatic effect by inhibiting the formation of dihydrofolic acid from para-aminobenzoic acid. Sulfamethoxazole can also be bactericidal when combined with trimethoprim for a synergistic effect. And trimethoprim exerts the bactericidal effect by inhibiting the formation of tetrahydrofolic acid from dihydrofolic acid. The last class is cell membrane inhibitors, and they are also bactericidal antibiotics. Examples are your cyclic lipopeptides, for instance daptomycin, which causes a rapid depolarization of cell membrane, and DNA, RNA, and bacterial cell death. Polymyxins is another cell membrane inhibitor, with the example of colistin, which acts on the outer membrane of bacteria by destabilizing the phospholipid and lipopolysaccharides present. The pharmacokinetic and pharmacodynamic properties are very important for optimizing antibiotic dosing regimens. Just to recap, pharmacokinetics involves the antibiotic's concentration and time in the host, and it's affected by absorption, distribution, metabolism, and excretion. Pharmacodynamics, that is the effect of the antibiotic once it reaches the infection site. The binding of antibiotics to protein affects the availability of the free drug. And remember, it's only the free drug that is active. After absorption, the distribution influences the extent of antimicrobial activity. The volume of distribution of hydrophilic antibiotics, which includes aminoglycosides, the beta-lactams, glycopeptides, and polymyxins, will be affected by the amount of body water. For instance, in patients with ascites or burn patients or patients with heart failure, because they are edematous. So that will affect your hydrophilic antibiotics, the distribution of your hydrophilic antibiotics. The same with lipophilic antibiotics, which include your fluoroquinolones, your macrolides, digacycline, and lincosamides. They will have a large volume of distribution in obese patients. The site of infection is important to note. For instance, antibiotics that cannot penetrate the blood-brain barrier will be inappropriate to use in, for instance, meningitis. It is important to individualize treatment and to monitor the patient. The main PK/PD parameters that correlate with the efficacy of antibiotics are the ratio of peak serum drug concentration to MIC and the ratio of area under the concentration versus time curve to MIC. An antibiotic should always be given at the right dose, at the right dosing intervals, to be within the therapeutic range. Because if you're not going to give antibiotics, especially your time-dependent antibiotics, according to the prescribed intervals, the concentration would fall under the MIC or under the minimum effective concentration and be subtherapeutic. Therefore, it will exert no pharmacologic effect but only cause side effects. The knowledge of PK and PD parameters is of value in optimizing the dosing regimens for all antimicrobial agents. Antibiotics can be classified according to their pattern of antimicrobial activity, meaning concentration dependent, time dependent, or both. Time-dependent antimicrobials have antimicrobial activity that depends on the duration that the pathogen is exposed to the antibiotic. Examples of time-dependent antibiotics include your beta-lactams, carbapenems, linezolid, your macrolides, and lincosamides. To optimize or to maximize the efficacy of time-dependent antibiotic, you can give the antibiotics at higher doses, you can increase the dosing frequency, increase the duration of infusion, or give a continuous infusion. The percentage of time during the dosing interval that serum drug concentration exceed the MIC is the only PK/PD parameter that correlates with beta-lactam efficacy. Concentration-dependent antibiotics include your aminoglycosides, metronidazole, fluoroquinolones, daptomycin, and others. And the higher the concentration of these antibiotics at the site of infection relative to the bacteria's MIC, the greater and faster the antimicrobial activity. Some antibiotics can be both concentration and time dependent. And examples hereof includes fluoroquinolones, aminoglycosides, azithromycin, tetracycline, glycopeptides, tigecycline, and linezolid. Antibiotics can furthermore be classified as either narrow spectrum or broad spectrum, depending on the range of bacteria it exerts its effect. Narrow spectrum antibiotics include your penicillin G and vancomycin. Broad spectrum antibiotics include your aminoglycosides, macrolides, tetracycline, second generation cephalosporins, quinolones, and some synthetic penicillins. For example, your aminopenicillins, cloxacillin, etc. Other videos will cover the different bacteria and the various antibiotics with their spectrum of activity. Only certain antibiotics exert an anaerobic effect. Bacteria can either be obligate anaerobic or facultative, depending on its need for oxygen. This is, however, covered in more detail in another video. Anaerobic infections are usually mixed with aerobic bacteria, thus polymicrobial. Antibiotics with anaerobic cover include tigecycline, metronidazole, chloramphenicol, carbapenems, clindamycin, and penicillin in combination with a beta-lactamase inhibitor. Treatment of anaerobic infections are complicated due to its slow growth during cultivation. It is important to manage anaerobic infections effectively by surgical drainage, debriding of necrotic tissue, draining of pus, improving the blood circulation, alleviating obstruction, and increasing tissue oxygenation. To use antibiotics appropriately, It is important to understand the different bacteria and to know which bacteria will be sensitive for which antibiotic. Keep an eye out for my videos addressing this. If you have enjoyed this video, please give me a thumbs up and subscribe to my channel. As always, all the resources I have used can be found in the description below. Until next time, thank you and bye-bye.